For more than a decade, North Carolina declined to expand Medicaid and neglected behavioral health care. But now the state is catching up fast. Today, record numbers of North Carolina residents are enrolling in Medicaid, and the state is investing $1 billion in behavioral health care. What's behind these big changes, and what can quality advocates learn from North Carolina's experience? We'll hear from the man in charge of it all, North Carolina Secretary of Health and Human Services, Kody Kinsley. Secretary Kinsley, welcome to Quality Matters.
Great to be here, Andy.
I want to start with something Axios wrote about you recently. They identified you as someone who grew up in Wilmington, North Carolina without health insurance. How do you think that experience shapes what you're doing as secretary?
I saw how access to healthcare and the cost of healthcare weighed on my family every day. Until recently, it was too common for people in North Carolina to be without health insurance. Roughly 1.2 million people that were stuck in the coverage gap. I was one of them. My mother had to work really hard with whoever and however to get us access to care, whether that was with a pediatrician that would see us on a sliding scale, going to a federally qualified health center. That was a formative experience.
Growing up without health insurance is a big reason Kinsley is focused today on the costs of care and access to care.
It was the fear that something could go wrong. My father ended up having a massive stroke in his 50s, and one of the first thoughts in my mom's mind was, how in the world are we going to afford this? Shaped and drives me today trying to increase access. We are very excited to have, after 10 years, been able to finally expand Medicaid. And not only have we gotten it done, we've gotten it done well. We estimate about 600,000 people are eligible for coverage under Medicaid expansion. We're over 460,000. 6 months into Medicaid expansion, and we're already more than 3/4 of the way towards a 2-year goal. We're getting people signed up really fast. Folks are not just getting covered, they're getting care. So it's an exciting time in North Carolina from an access and coverage perspective.
As impressive as Medicaid expansion is, the implications for behavioral health may be most important.
The other thing that's particularly exciting was a near $1 billion investment in behavioral health that is just so consequential to health, and something that had also been forgotten and neglected for too long. We've been working aggressively to increase Medicaid rates for behavioral health providers for the first time in over a decade. We've invested tens of millions of dollars in behavioral health urgent cares, facility-based crisis programs, and more novel innovations like co-responder models. I'm really beefing up our 988 call center to move our continuum of care from one of constant crisis to one of really comprehensive care.
North Carolina's innovation has caught the attention of quality researchers.
Hi, I'm Julie Seibert. I'm the Assistant Vice President of Behavioral Health at NCQA. North Carolina is one of the states that has Medicaid expansion. It's exciting for a couple of reasons. At NCQA, we're focused on access and positive outcomes for individuals with behavioral health disorders. Non-expansion states, individuals with mental health and substance use disorders represent a larger share of the uninsured population. One study shows that Medicaid expansion states correlate with a huge decrease in suicide rates for non-elderly adults, and some studies that show that there's a higher percentage of individuals with substance use disorders that can access needed care. So with Medicaid expansion, we'll see increased access to mental health and substance use care for our most vulnerable citizens.
Julie goes on to draw a connection between what Kody Kinsley is doing in North Carolina and what NCQA is doing with HEDIS.
Like many other states, they're struggling to make sure that there are enough behavioral health workers. They're using peer specialists to man peer warm lines. So individuals who are calling 988, they're using to provide additional support services. At NCQA, we see the value of expanding the behavioral health workforce, and we too have tried to include peer support specialists in new ways to increase that access. We're doing that through the inclusion of peer specialists in two of our most highly used HEDIS measures: follow-up after inpatient hospitalization and follow-up after ED use for mental health reasons. Historically, these measures have only counted psychiatrists, psychologists, and social workers as appropriate follow-up after in-hospital visits, but we expanded that because we recognize that peer specialists have a great deal to offer. They support engagement of individuals with mental illness, and they pull them into treatment and they keep them in treatment. So we are trying to recognize and expand the workforce through our HEDIS measures.
How has Kody Kinsley managed to get all this done? In a word, bipartisanship. He's been called North Carolina Republicans' favorite Democrat.
To get us to here, Governor Cooper built this non-traditional coalition of people to rally the political will. So it was chambers of commerce in every community. It was county commissioners in some of our most rural towns who said, look, this is a business investment. We also had an extensive ground game of healthcare navigators in communities. We equipped faith leaders and civic organizations to get their communities engaged, to bust myths about who's eligible, because a lot of these folks, they've applied for Medicaid before and failed. So we had to give enough education to make it as easy as possible for them. We're excited about that progress. A lot of folks needed care for a long time, and I'm glad they're finally getting it. My amazing team that is always thinking clever and outside of the box opportunities to solve problems. We're kind of relentless and eager problem solvers. I really appreciate the partnership with people in my role in other states. And here's what I'll tell you. When I pick up the phone, or when I go to these meetings, whether it's someone from big state, small state, red state, blue state, purple state, whatever, we're often dealing with the same issues. How we talk about it, how we try to people get to solve it, the learning from each other is rich and diverse. There's different applications, different problems, different ways that we approach it, but the kind of core big picture is often the same things.
You mentioned North Carolina's $1 billion investment in behavioral health. What problems are you trying to solve with that huge infusion of money?
Behavioral health is essential to health. And for too long, behavioral health has been ignored. We've often thought of mental health as a moral failing and not a medical issue. Unfortunately, these things are coming to a head at a time when most of our country's mental health system has been ignored and forgotten. North Carolina recognized that, look, without Medicaid expansion and insurance coverage, we were never going to be able to adequately serve those folks, especially people with chronic mental illness issues. We were able to get our General Assembly to invest a significant amount of that into rebuilding a behavioral health system. We have seeded money for more behavioral health urgent care so that folks don't have to go to the emergency department. They have an alternative place to go. If they need somewhere to stay longer than 23 hours in kind of a stabilizing assessment space, then facility-based crisis centers and CCBHCs as part of infrastructure across the state. Now, look, this is all one-time dollars, and we can get it off the ground, but we need Medicaid to sustain it.
I get the impression that you are the captain of a re-resourced or rejuvenated team that has a big game of catch-up to play with regard to behavioral health. Mental Health America, a national advocacy group, has ranked North Carolina 39th in the country for access to treatment. How did such a large, prosperous state get so behind?
It's a challenge I don't think is unique to North Carolina, treating behavioral health issues as a moral failing as opposed to a medical issue. Stigma is the foundational problem. When someone has a heart attack or they're diagnosed with cancer, the neighbors show up. People bring food, they check in on them, they see what they're doing, ask if they want to be driven to their appointments. But when someone's struggling with addiction or a mental health issue, people kind of disappear. Those loss of community connections only make it worse. And that was replicated in our policymaking. And for a really long time, we thought that mental health issues only afflicted the weakest among us, and we preserved any services and supports for folks only once they hit rock bottom. We know about chronic mental health that if we only treat people when they hit rock bottom, you're never going to get them back up to baseline. And challenging those chronic illnesses is really hard. The second issue is if you don't pay for mental health from a treatment and prevention perspective, you will pay for it in other places. You will pay for it as communities struggle with homelessness. You will pay for it in lost economic productivity as people struggle to maintain work. You will pay for it in your jails where 60% of people have a substance use disorder and many of them have a co-occurring mental health. Often, we're paying for it in all the wrong ways and losing lives. But sometimes it can be really hard to inspire people to say, let's jump up to the investment phase and transition the system of care. I wanted to turn the system on its head to move us from playing catch up in crisis care to moving towards prevention and constant care. It's taken a while, but we're off to the races. The other area that I think is really important, that open question to all of our friends listening: what is the right behavioral health, public health model of intervention? How do we equip communities to be healthy and resilient from a behavioral health perspective? We've got to get more upstream and integrated with primary care. Behavioral health is a primary care issue. It's not a specialty care issue. Significant depression and anxiety issues can be addressed at the primary care level, but a lot of primary care providers are not educated on these issues in their medical education, and they're not resourced appropriately. The gold standard is collaborative care models at every primary care practice that provide access to curbside consults from psychiatry and care managers to work between visits to help address med management and other things. From a long-term perspective, social determinants of health are really both sides of the coin. We're talking about people struggling with poverty, and if they are, it's really hard to be healthy. Health, as much as food, transportation, employment are drivers of health, health is an indicator of poverty. For the behavioral health community, so when we are working to support someone in recovery from substance use disorder or serious mental illness, their ability to maintain work and to maintain housing with appropriate supports is mutually beneficial from a very long-term perspective.
One area where Kinsley is thinking differently is in how the healthcare system interacts with the prison system.
One of the areas that I'm most excited about is our justice-involved work. I believe if we went to jails or prisons and we saw 60% of people having diabetes as a healthcare issue, we would ask questions about what's on the menu, why are we criminalizing diabetes, what's going on. Yeah, that's what we see with substance use disorder and mental health issues. And we have to then think about what are the policy choices that help these things be commingled. We can do the important things and make sure that we can tell the signal from the noise, what we call the sequential intercept model, to intervene early, starting with pre-arrest diversion, give people care, don't put them in jail if what's really going on is an addiction issue, jail-based treatment, capacity restoration, reentry supports. At every potential intercept, how do you break the cycle, behavioral health courts, etc. I'm not suggesting that people shouldn't be accountable for crime. The point is, when someone is dealing with severe mental illness or addiction and their behaviors are masquerading as crime, then let's get to the root cause. One of the programs that we've instituted, we've done now tens of millions of dollars in justice-involved work, pre-arrest diversion, jail-based treatment, for a quarter of the cost. And there's another win here, which is we're essentially bringing access to treatment and services in jails. And so it speeds up the judicial process. It helps people faster. If people aren't going to my state psych hospitals, the people who are sitting in emergency departments who need to go there can. If we all work harder on decoupling these systems and making sure that we're getting people who need healthcare, and getting people who need justice-involved processes, that will work better.
And with regard to that long-time sustainability, what are you doing, or what do you feel like you need to put in place to make sure that that sustainability is there?
We also need private insurance to step up, make sure that they're paying for behavioral health services to sustain it. The first thing that we did was increase the behavioral health rates in North Carolina for the first time in over a decade. We looked at where folks were getting stuck in our system and how does payment incentivize providers to staff up or to take on more complicated cases. We couldn't expect providers to do what they do today on what they used to get paid 12 years ago. You wouldn't expect anyone to go to the grocery store and buy it for the price they paid 12 years ago. I am bullish that these policy changes are here to stay because they have been so popular. At the same time, execution matters. The best policy lives or dies by implementation and getting it done well. Conversations about experience and the ability to run organizations and to get things done is really important for the moment. I don't think the policy aspects are particularly political right now. It's more, let's check resumes and get the right people in the job to do the work. And yet we were expecting that of our behavioral health providers. So we nearly doubled our inpatient psych rate. We significantly increased our psychological assessment rate because we saw that was where people were getting stuck. There's more to do. When we think about behavioral health, social determinants of health or drivers of health, new vital signs of health, if you will, food, transportation, interpersonal safety, and employment. linking people to these things has been another foundational aspect of sustaining behavioral health care, because those things drive health. They're also good indicators that people with complex behavioral health needs are well. If they are able to sustain housing, if they're able to go to work, those things are mutually reinforcing for overall behavioral health. So this is where our work on behavioral health dovetails so beautifully with our work to increase access to these services, and having the first in the nation pilot to invest in those things. And we've had a lot of really positive outcomes.
Here again, Julie Seibert.
Access to food, access to transportation, personal safety, and employment. We know for behavioral health treatment to be effective that these very basic needs need to be met and attended to. So at NCQA, we've developed a social needs screening and intervention measure that we hope to include in our products and be included in HEDIS.
Our Healthy Opportunity pilots invest in 4 foundational drivers of health: food, interpersonal safety, transportation, and employment. We found a reduction in emergency department visits, a reduction in hospitalizations, and a savings net of costs of $85 per member per month. When you think about the headwinds of underserved community in our more rural parts of the state, and you're able to achieve that, it's remarkable. Not to mention that this now stable funding source for these community-based organizations, because we've created networks of community-based organizations that are billing Medicaid for these services rendered. What's so exciting is more than 3/4 of them are minority or women-owned. These are people that were doing the work on donation and hopes and prayers, and now they have more sustainable funding. So they're building capacity, they're maturing, they're able to do more in their communities. We're negotiating with the federal government to take this pilot statewide, to be in all 100 counties, to learn from the pilot so far as what other services we need to invest in that are going to lean us even harder into health. We're doing the secondary analysis on those first 2 years to understand just what sort of health outcomes did we see. North Carolina wants to be transparent. Everybody else can learn from this. It's challenging when you're building out these networks. I don't walk into any room and say, who's excited about medical billing? The crowd doesn't cheer, And so while on one hand, using traditional Medicaid dollars to fund community-based organizations to do this work is exciting, we're also medicalizing social services, and that's hard for them, hard to build the infrastructure. It's a high cost, a high marginal cost, high transaction cost. That's something we still have to wrestle with. The other thing that's related to that, we've looked at who's in Medicaid, who's in SNAP, and who's in WIC. SNAP and WIC being foundational around key goals, maternal health and family health. And when we think about using Medicaid dollars to invest in food, we should ask the question, how many people are in those foundational programs? We found, looking at the matching of the people between them, that if we had perfect enrollment, our SNAP program would double. So we're leaving a lot of federal SNAP dollars on the table that's not getting food on the table. And so now we've started to pull the string on that. We've understand the marginal benefit of the SNAP program is too small for the person to feel like doing the paperwork is worth it. The administrative burden is too high. There's an opportunity to improve that. If I could be a magician, I would love, if you were in Medicaid, you could be in SNAP automatically. We could ease those burdens for people. We could save the government money from administering programs, and we could get the value out of investing in food, even in a program with a high transactional cost.
I wonder, can you tell us about advice that you might have for people who care about improvement but don't live in North Carolina? In other words, people in the other 49 states. What are you doing that maybe they can apply where they are?
We need to continue to learn, because we're just not achieving the value-based dream fast enough. We're still paying an incredible amount of money for more stuff and not more care. We got to lean harder towards value. Not investments in behavioral health are a no-brainer opportunity, and they've been so underinvested in that we can pay for a lot more behavioral health stuff and still give value. There's a lot of non-evidence-based efforts in the behavioral health space, and we need to make sure that we continue to reinforce what works. From a long-term perspective, social determinants of health are really both sides of the coin. We're talking about people struggling with poverty, and if they are, it's really hard to be healthy. Health, as much as food, transportation, employment, are drivers of health. Health is an indicator of poverty. For the behavioral health community, so when we are working to support someone in recovery from substance use disorder or serious mental illness, their ability to maintain work and to maintain housing with appropriate supports is mutually beneficial from a very long-term perspective.
We'll post this episode in June, and June, of course, is Pride Month. You identify as a gay man, and I'm curious how your position in North Carolina makes you think about Pride Month.
Well, to be an openly gay individual who is appointed by the governor and confirmed unanimously by the North Carolina Senate, it gives me great pride to be able to serve my state. It wasn't far too long ago when that would have been nearly impossible for someone to be openly gay and in a position of public trust. Not even too long before that, especially in the federal government, they would have been found and rooted out. I bring a particular perspective based off my own lived experience, but when we try to solve problems, we try to build a table that brings folks to the table who we're partnering with. Their lived experience is key. We all saw that firsthand during COVID in the way that we talked about vaccines. We needed to have trusted messengers. We needed to have programs shaped by the people that they were meant to serve. Being a gay man is one part of my broader identity, and I bring my whole self to work, and that informs our work. And so as we think about our policies, we don't need to just do broad sweeping categorical exclusions. We need to be very nuanced. I think more nuance in all of our conversations right now is beyond needed. People are in a very reactive space. People are quick to judge, quick to be offensive, almost constantly aggrieved. I think being able to stay in tension with people, to be willing to disagree and have tough conversations and not let that destroy relationships, but then get to that nuance is my approach at policymaking and problem solving. It's why I think we've been able to advance complex public policy and achieve amazing outcomes for people because we've been willing to wade into that level of nuance.
That's well put. One last question. What advice would you have for our audience, people who care about the issues that you work on, and what might you ask of our audience?
I guess I would go back to the good guidance my mother gave me as a child when she was navigating whatever it took, powered by the love of a mother, to find access to healthcare and services for her two children. And that is work with whoever, do whatever to figure it out. And I think that advice has served me well, from modeled by her example, and I think that advice serves us all well. It is easy to get discouraged in the healthcare arena. We have been on a long arc bending towards improvement for a very long time. And yet it can feel easy to kind of be discouraged by that, even when there is so much promise. And I just want to tell people to stay in it and to keep going. If you've got great ideas, move to North Carolina and do them. We're ready for you. I would ask people to lean into the conversation. This is a time more than ever where we need to be talking to each other. And unfortunately, more people are getting isolated. If we're going to continue to expand access, if we're going to continue to fight underlying drivers of bad health, and if we're going to go after costs on healthcare, it's going to take creative problem solving. And more than people getting out of their silos, it's going to take just dramatic engagement with people who think differently from ourselves.
I think that's a great place to end it. The North Carolina Secretary of Health and Human Services, Kody Kinsley, thank you for being on Quality Matters.
Thanks, Andy. It's been great to be here.
Thank you for listening to Quality Matters. You can always learn more at ncqa.org, and be sure to subscribe to Quality Matters wherever you get your podcasts. We'll see you next time.